Your breast is never just sitting there. It's one of the most responsive structures in your entire body. It shifts during puberty, during your period, during pregnancy, during breastfeeding, and again at menopause. Every change has a reason. But there's one cause behind some of those changes that almost nobody talks about. And it's not breast cancer. It's a condition called Sjogren syndrome. Today we are going through 8 signs in your breast that can point to it, and ignoring them is the mistake that costs people years of misdiagnosis. Before we go further, here's the 30-second map you'll need for everything that comes next. Your breast is shaped like a teardrop, sitting at a slight diagonal across your chest rather than flat the way most diagrams show it. The raised tip is the nipple. The darker ring around it is the areola, and those tiny bumps you sometimes feel there are Montgomery glands, small oil glands that keep the area lubricated. Behind the nipple, ducts run back through the breast like branches, connecting to the lobules, the actual glandular units. Together, the ducts and lobules make up what's called glandular tissue. Everything else is fatty and fibrous tissue, called stroma. The breast tapers into a tail reaching toward your armpit, and the fold where the breast meets the chest wall is the inframammary crease. Running through all of it is a dense network of lymphatic vessels, draining toward lymph nodes in your armpit, the axillary nodes, and near your collarbone, the supraclavicular nodes. Hold on to that picture. Every one of the 8 signs we are about to cover traces back to one of these structures. There's a version of Sjogren syndrome that most patients never hear about. Not the dry eyes. Not the dry mouth. Not the fatigue. Those are well known enough now that even a general practitioner usually catches them. The version almost nobody talks about is the one that reaches into breast tissue and causes changes that can mimic infection, mimic cancer, and in rare cases, become cancer if they are missed. This isn't a fringe theory. It's documented in peer-reviewed literature going back more than 2 decades. The connection between Sjogren's and breast pathology is real, it's mechanistically understood, and it's criminally underrepresented in the conversations patients are having with their doctors. So today, we are fixing that. If something in what I've just described already sounds familiar to you, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where standard testing is most likely to miss it. Type symptom map in the comments and I'll send it to you directly, because the stage you're in changes everything about what happens next, and that's exactly what this map breaks down. This video is for you if you've been diagnosed with primary Sjogren's, secondary Sjogren's overlapping with lupus or rheumatoid arthritis, or if you're still waiting on a diagnosis but living with dry eyes, dry mouth, joint pain, fatigue, and the sense that your immune system is working against you. Stay until the end. There's information here that could genuinely change your health trajectory. Here's why all of this reaches the breast specifically. Sjogren syndrome is a systemic autoimmune disease where the immune system mounts a chronic, misdirected attack on the body's exocrine glands, glands that secrete outward through a duct. The classic targets are the lacrimal glands that produce tears and the salivary glands that produce saliva. But here's the part that almost never gets mentioned. The lobules and ducts in your breast are exocrine glands too. They share immunological and structural traits with your salivary and lacrimal glands, and that shared biology makes them vulnerable to the same attack. What happens at the tissue level is called lymphocytic infiltration. Immune cells, mainly CD4 positive T cells and B cells, accumulate in and around glandular tissue and start damaging it. In the salivary glands, that produces dryness. In the lacrimal glands, dry eyes. In breast tissue, it shows up differently, because the breast isn't just a secretory organ, it's fatty, fibrous, glandular, and heavily lymphatic, all at once. That infiltration can produce masses, fibrous nodules, ductal changes, and lymphatic disruption, a cascade that deserves real attention. And beyond the local damage, the chronic systemic inflammation Sjogren's generates, elevated cytokines, abnormal immune cell proliferation, is in some patients the same pathway that eventually crosses from inflammation into malignancy. That's the long-term risk that makes monitoring non-negotiable. With that as the foundation, let's go through the 8 signs. Sign 1. A breast lump that doesn't resolve. This is the sign that gets the most attention in Sjogren's breast research, and for good reason. The specific condition is called lymphocytic mastitis, also known as sclerosing lymphocytic lobulitis, a benign but significant inflammatory condition where lymphocytes accumulate within and around breast lobules and ducts, the same basic process happening in your salivary glands. What does it actually feel like? Usually firm, sometimes hard. Smooth-edged or slightly irregular. Often movable, though in some cases more fixed. It may or may not be tender, and painless lumps tend to draw more clinical concern than painful ones, precisely because they are less expected. Here's the trap: this lump doesn't behave on imaging. On mammography, it can look like a dense, suspicious opacity. On ultrasound, it can read as a hypoechoic irregular mass, language that routinely triggers a biopsy referral. There are documented cases of Sjogren's patients undergoing surgical excision for what looked like a suspicious mass, only for pathology to come back as lymphocytic mastitis. The autoimmune history was the missing piece the whole time. That's why telling your doctor you have Sjogren's isn't optional. It changes the entire differential from the start. And one more thing, lymphocytic mastitis itself isn't cancer, but the immunological environment producing it is the same environment that raises malignancy risk over time. It's not a lump to biopsy and forget. It's a signal that your breast tissue is immunologically active and needs ongoing surveillance. The best time to do a careful self-check is the week after your period ends, when breasts are least hormonally swollen. Post-menopause, just pick a consistent day each month. You're not hunting for anything specific, you're learning your normal so anything that changes actually stands out. Comment lump below if you've ever found a lump that turned out to be inflammatory rather than cancerous. Sign TWO. Breast pain that doesn't match your cycle. Most premenopausal women get some cyclical tenderness in the 2 weeks before their period. That's normal. What's not normal, and what Sjogren's patients need to flag, is pain that doesn't follow that pattern. Pain after menopause, pain focused in one spot rather than diffuse, or pain that simply feels different than anything you've felt before. Multiple studies have found that women with primary Sjogren's have a higher prevalence of fibrocystic breast changes than age-matched controls without autoimmune disease. The proposed mechanism: chronic inflammation promotes fibrous tissue growth and cyst formation, leaving tissue that feels lumpy, dense, and tender. Patients often describe it as heaviness in the upper outer quadrant, a dull ache, pressure from the inside, or a bruise with no injury behind it. The tissue can feel nodular, almost pebbly. But there's a second pathway here that's easy to miss: neuropathic pain. Sjogren's is well documented to cause small fiber peripheral neuropathy throughout the body, and the breast has extensive nerve supply. When that neuropathy reaches breast tissue, it produces burning, shooting, or hypersensitive pain that doesn't resemble normal tenderness at all. Patients often say it just feels wrong. If pain is new, has lasted more than a few weeks, sits on one side only, or comes with any other breast change, get it evaluated. Comment pain if you've had breast pain you weren't sure how to explain. Sign 3. Redness, heat, or swelling without breastfeeding. Most people only learn about mastitis in the context of nursing. Bacteria entering through cracked nipple tissue, infecting the ducts, producing redness, warmth, swelling, and sometimes fever. That's lactational mastitis, and antibiotics clear it. What Sjogren's patients need to know about is non-lactational mastitis. The same redness, warmth, and swelling, but with no pregnancy or breastfeeding involved. The lymphocytic infiltration driving your disease elsewhere can produce an inflammatory response in breast tissue that looks exactly like infection, which is why the first response is usually antibiotics. Here's where it gets dangerous. If symptoms improve but don't fully resolve, or improve and come back, that's no longer consistent with simple bacterial infection, and at that point, imaging is essential. What needs to be ruled out is inflammatory breast cancer, a rare but aggressive subtype that doesn't present as a lump at all. It shows up as diffuse redness, skin thickening, warmth, and sometimes an orange peel texture, and it doesn't respond to antibiotics, full stop. Some research has found elevated breast cancer incidence in women with primary Sjogren's compared to the general population, with proposed mechanisms including chronic immune activation and abnormal B-cell behavior. That doesn't mean you'll develop it. It means your inflammatory baseline raises the stakes on any new redness, warmth, or swelling. Rule of thumb: if you're prescribed antibiotics for breast redness and symptoms haven't substantially improved in 7 to 10 days, go back and ask for imaging before starting a second course. Sign 4. Skin dimpling or an orange peel texture. Peau d'orange, French for orange skin, describes a breast surface with multiple small indentations and visibly enlarged pores, like the textured rind of an orange. Once you've seen it, it's unmistakable. The mechanism is lymphatic obstruction. The skin is anchored to underlying tissue by fibrous bands called Cooper's ligaments and threaded with lymphatic channels. When drainage is blocked, fluid backs up in the skin, thickening it and pulling tight at the ligament anchor points, creating the dimpling. This matters for Sjogren's patients for two reasons. First, your disease disrupts lymphatic architecture as much as glandular tissue. The lymphoid aggregates and B-cell activation that define Sjogren's can impede lymphatic flow anywhere, including the breast. Second, and more urgently, peau d'orange is a cardinal sign of inflammatory breast cancer, and it's also associated with breast involvement in non-Hodgkin's lymphoma, a cancer Sjogren's patients carry significantly elevated risk for. The specific subtype most linked to Sjogren's, malt lymphoma, usually arises in the salivary glands, but documented cases exist of primary breast malt lymphoma in Sjogren's patients. Don't file this under skin condition. It's a structural sign that something is disrupting your breast's lymphatic architecture from the inside. See your doctor urgently. Sign 5, nipple changes, inversion, discharge, or a persistent rash. 3 specific changes here deserve individual attention. New nipple inversion, a nipple that used to point forward and now turns inward, means something beneath it is pulling the tissue in. That could be a contracting fibrous mass, an inflammatory collection, or a tumor. In a Sjogren's patient, lymphocytic mastitis sitting directly beneath the areola is on that differential. Nipple discharge matters based on its character. Milky discharge from both nipples, only when squeezed, is far less concerning than discharge that's spontaneous, one-sided, clear, and watery, or blood-tinged. Chronic ductal inflammation in Sjogren's can also produce intraductal papillomas, small benign growths that cause bloody discharge. Any one-sided or spontaneous discharge needs imaging. And a rash around the nipple or areola, red, flaky, itchy, crusted, is easy to write off as another dryness symptom when you already have Sjogren's-related skin issues. The problem: Paget's disease of the breast looks almost identical to nipple eczema, but is actually a cancer involving the nipple skin. It typically affects only one side, doesn't respond to standard eczema treatment, and often has a deeper mass underneath. A rash that's lasted weeks and isn't responding to moisturizer needs a dermatology referral and ideally a punch biopsy. Comment nipple if you've had a change in this area you weren't sure how to bring up. Sign 6, a new asymmetry or shape change. Natural asymmetry is the rule, not the exception. Most women have one breast that's slightly different from the other, and always have. What matters is change, a shape that's different than it was, a nipple that's shifted position, fullness on one side that's appeared without a hormonal explanation. An inflammatory mass, even an entirely benign one made of immune cells, takes up physical space. Depending on where it sits, it can push outward and create a visible bulge, or tether the skin through Cooper's ligaments and create a flattening instead. Fibrocystic changes, more common in Sjogren's, usually affect both sides evenly, so when one side changes significantly more than the other, that asymmetry is the signal worth chasing. The best way to track this is visual, not just by feel. Stand in front of a mirror with good lighting, arms at your sides, then raised overhead. Raising your arms puts tension on the tissue and makes dimpling or asymmetric fullness far more visible. Then lean forward slightly. That position reveals retraction that's invisible standing upright. Do this often enough that you actually know your baseline. Comment shape if a change in contour ever led to a finding for you. Sign 7, swelling or firmness in the armpit or collarbone. Sjogren's causes lymphadenopathy, swollen lymph nodes, as a recognized baseline feature in some patients. Which creates a real problem. When swollen armpit nodes are already part of your disease, how do you tell the difference between that and a node reacting to something new in the breast? The axillary nodes are the breast's primary drainage site. If something's wrong inside, infection, inflammation, malignancy, these nodes often respond first. And the supraclavicular nodes near your collarbone carry heavier clinical weight. Involvement there, in the context of breast disease, tends to track with more advanced staging. So what separates routine Sjogren's lymphadenopathy from something new? Laterality, one side suddenly more swollen than the other, against a baseline that's usually symmetric. Texture, inflammatory nodes are typically mobile and soft, while malignant ones often feel harder and more fixed. Whether there's matching pain in the breast on the same side. Whether it's been growing over weeks. And whether you have any of the classic 3, unexplained weight loss, night sweats, persistent fever, alongside it. which together with lymphadenopathy point toward lymphoma and warrant immediate evaluation. Given that Sjogren's patients carry a significantly elevated non-Hodgkin's lymphoma risk, new one-sided armpit swelling isn't something to wave off as just my Sjogren's. Comment nodes if lymph node changes have been part of your experience with this disease. Sign 8. Unexplained heaviness or internal pressure. This is the hardest one to talk about, because there's nothing to point to. No lump. No rash. Nothing that photographs. Just a heaviness, a pressure from inside, a fullness that doesn't match your cycle and doesn't go away. 4 mechanisms can produce this in Sjogren's patients. Fluid accumulation, when disrupted lymphatic flow causes interstitial swelling before it ever becomes visible as peau d'orange, meaning heaviness can be the earliest signal, before anything shows on the skin. Ductal ectasia, where chronic inflammation causes the ducts to widen, creating pressure deep behind the areola where the major ducts converge. Amyloidosis, extraordinarily rare, but documented in Sjogren's and other connective tissue diseases, where misfolded proteins replace normal tissue and create a firm, diffuse thickening rather than a focal lump, often hard to distinguish from malignancy on imaging. And neuropathic involvement, small fiber nerve damage producing real, physical pressure-like pain with no structural cause at all. Don't dismiss this because it's not visible. Describe it precisely to your doctor: how long, which side, constant or intermittent, whether it tracks with your cycle, whether it's intensifying. That history, paired with an exam and the right imaging, gets you real answers. Comment pressure if this is something you've been living with. Start with knowing your own baseline, not the general population's. Your tissue with Sjogren's may already run more nodular or tender than average. Learn what's normal for you, document it, and note how it shifts across your cycle if you're still cycling. Then bring imaging into the conversation directly rather than waiting for your doctor to raise it. Given my Sjogren's diagnosis and documented lymphoma and breast pathology risk, what surveillance schedule do you recommend for me? And know which doctor gets which symptom. Lumps, pain, nipple, and skin changes go to your gynecologist or breast specialist first. Constitutional symptoms, weight loss, night sweats, fever, alongside new node changes go straight to your rheumatologist as a possible lymphoma signal. Neuropathic pain with no other findings is a rheumatology and neurology conversation about Sjogren's neuropathy itself. Here's why this matters so much. A radiologist reading your mammogram may not have Sjogren's anywhere in mind when characterizing a mass. A breast surgeon evaluating your lump may not know your lymphocytic infiltrate has autoimmune significance beyond being benign. The research backs this connection clearly. Lymphocytic mastitis tied to autoimmune conditions including Sjogren's, fibrocystic changes elevated in Sjogren's populations, and non-Hodgkin's lymphoma risk consistently the most robust finding in this space, with some studies estimating it well above general population rates in patients with more systemic involvement. The breast cancer data itself is more mixed and still an active research area, but the lymphoma risk is settled enough that it belongs on the differential every time. None of this is common knowledge in a general breast clinic yet. That's exactly why you lead with your Sjogren's diagnosis at every appointment, not as a footnote, but as the reason you're there. One more piece worth knowing: some of this can be medication-driven. Hydroxychloroquine itself isn't linked to breast pathology and is considered safe on this front. But immunosuppressants like rituximab can mean infections, including mastitis, progress faster and more atypically, so any redness or swelling while on these needs to be reported promptly, not watched. And certain antidepressants or antipsychotics used off-label for Sjogren's-related sleep or pain issues can raise prolactin, which causes its own nipple discharge and engorgement, worth ruling out with your prescriber before any invasive workup. The breast contains exocrine glands. Sjogren's targets exocrine glands. That's the whole story, and it's why this matters. So let's bring it together, fast. A lump that won't resolve. Pain that breaks the pattern of your cycle. Redness and heat that antibiotics don't fully clear. Skin that looks like orange peel. A nipple that changes shape, leaks, or grows a rash that won't quit. A breast that looks different than it did 3 months ago. Lymph nodes swelling on one side only. A heaviness you can't explain but can't ignore. None of these mean cancer on their own. What they mean is that your body is handing you information, and it's on you to put that information in front of your medical team with your full Sjogren's history attached. If you haven't grabbed the Sjogren's symptom map yet, it's in the description. a free resource built to help you track symptoms across every system so nothing gets missed at your next appointment. Add a breast section to what you're already tracking. Date, location, character, what changes it? If this surprised you, tell me which sign in the comments. And if you know someone with Sjogren's who's been brushing off breast symptoms as unrelated, send them this video. That's 5 seconds that could matter enormously. Comment symptom map if you're ready to start tracking your breast health alongside the rest of your Sjogren's picture.